It's 2:47 in North Toronto. The Uber driver in the front seat speaks 4 languages. He has 12 years of medical training. He spent 8 of them as an emergency room physician overseas. His credentials are recognized by the World Health Organization. They are not recognized by the College of Physicians and Surgeons of Ontario. There are roughly 13,000 doctors like him in this province alone, driving Uber, working as lab techs, parking attendants, security guards, holding medical degrees the Canadian system refuses to license. The headline coverage is, "We don't have enough doctors." What if that is wrong? What if Canada has plenty of doctors and the system is built to keep them out? Let's start with the official narrative. According to the 2025 Our Care Survey, 5.9 million Canadian adults do not have a regular family doctor or nurse practitioner, down from 6.5 million in 2022, but the day-to-day experience hasn't changed materially. From 2015 to 2025, the share of Canadians who report difficulty or no access to a family doctor rose by 25 percentage points. 250 emergency room closures in BC in a single year, 1,117 in Ontario, wait times amongst the worst in the OECD. The standard explanation? Not enough doctors are being trained. The boomers are aging, a reasonable, depressing, conventional story. Now look at the other side of the ledger. In Ontario alone, there are approximately 13,000 internationally trained physicians, not currently working as physicians. Across Canada, the number is significantly higher. Most of them pass the Medical Council of Canada qualifying exam. Most of them have years or decades of clinical experience overseas. They cannot get a residency match. Here's why. The Canadian Resident Matching Service splits residency positions into 2 streams. Canadian medical graduates compete for one stream. Internationally trained physicians compete for a separate, much smaller stream. Roughly 10% of total positions are largely confined to family medicine and a handful of underserved specialties. The 2026 R1 main match a total of 931 internationally trained physicians matched into residency positions across the entire country. The applicant pool is several multiples of that. The shortage isn't a shortage of doctors, it's a shortage of permission slips. This part is the part nobody tells you. In March of 1990, the Federal Provincial Territorial Conference of Deputy Ministers of Health hired 2 health economists, Boris Barra, a UBC, and Greg Stoddard at McMaster, to write a report of Canada's physician supply. The country was in recession. Public debt was a crisis. Provinces wanted to cut healthcare spending. Doctors are the largest line item in healthcare spending. The deputy ministers wanted a number. The report was published in 1991, known forever after as Barra-Stoddard. It concluded Canada had too many doctors. It recommended cutting medical school enrollment by 10%. It recommended cutting provincial postgraduate training positions by 10%. And it recommended reducing Canadian reliance on internationally trained physicians. Provincial governments implemented it almost immediately. By the late 1990s, the number of medical school admissions in Canada had dropped by approximately 10%. Family medicine residency positions were reduced. Provincial medical colleges added new layers of barriers to international medical graduate licensing. Then the population aged. Then immigration accelerated. Then the boomers needed more care, not less. By the early 2000s, the shortage was undeniable, and provinces began slowly raising medical school enrollment again. But the structural pieces, the residency cap, the IMG barriers, the exam bottlenecks, the provincial college gatekeeping, those stayed. The Canadian Medical Association Journal published a retrospective on Barra-Stoddard in 2023. The conclusion was direct. The policy decisions of the 1990s are still distorting the supply pipeline today, and they have never been formally reversed. The shortage isn't an accident, it's a policy still enforced. So what is the lockout in concrete terms? 5 layers. Layer 1. Medical school admissions. Even after the post-2000 reversal, Canada trains far fewer doctors per capita than peer OECD countries. The supply pipeline starts narrow. Layer 2. The residency matchup. Every Canadian medical school graduate has a near guaranteed residency. Internationally trained physicians compete for the IMG designated stream. About 10% of total positions. That is a hard cap, not a market outcome. It is set by provincial governments in consultation with provincial medical associations. Layer 3 is the exam structure. The Medical Council of Canada Qualifying Exam Part 1 and the National Assessment Collaboration Exam are required gateways. They run only a few times a year. Each attempt costs thousands of dollars. The wait times to even take the exam can run into months. Layer 4 is the provincial colleges. Each province has its own college of physicians and surgeons. Each one has its own credential rules, and internationally trained physicians licensed in Quebec cannot automatically practice in Ontario. A physician trained in the United Kingdom or Australia faces a different set of barriers than one trained in India or Egypt. Layer 5 is the new barriers in 2026. This is the part that broke the story for me. Beginning with the 2026 R1 match, Ontario introduced a brand new eligibility rule. Internationally trained physicians applying for the Ontario IMG residency stream must have completed at least 2 years on Ontario high school. A doctor with 20 years of clinical experience in Mumbai or Manila or Mexico City, who have passed every Canadian licensing exam, who has settled with their family in Toronto as a permanent resident, is now ineligible to apply in the first round of the residency match unless they were a teenager in Etobicoke. The rule has nothing to do with clinical competence. It has nothing to do with patient outcomes. That is what a regulatory cartel looks like. In plain English, what does this lookout cost in 2025? British Columbia experienced approximately 250 emergency room closures, the vast majority in rural communities. Ontario had 1,117 separate emergency department closures over the same period. The 100-mile house emergency department in BC closed 10 times in less than 4 months. In 2026 alone, when an ER closes overnight in a rural town, patients have to drive 90 minutes or more to the next hospital. People die in those cars. Across the country, emergency room hours lost since 2019 have exceeded 1.1 million. Wait times for cancer care, hip and knee surgery, and specialist consults consistently rank amongst the worst in the OECD. Provincial governments tell every camera the same thing. We need more doctors. We are working on it. We have launched a task force, a working group, a recruitment program. Meanwhile, in the same province, internationally trained physicians who passed every exam, who hold permanent residency, who live in a 30-minute drive from the closed ER, are not allowed to work that shift. There is a really thin line of progress. The 2026 R1 match did place 931 internationally trained physicians into residency, up from 671 in 2024. The College of Physicians and Surgeons of Ontario announced it is removing some specific barriers for credentiated physicians from the United States, the United Kingdom, Australia, Ireland, and a small list of other approved jurisdictions. Several provinces have stood up direct entry pilot programs. Each of those is a thimble across a flood. The structural problem is not technical, it is political. It is the willingness of the federal government to use its spending power to force harmonization. It is the willingness of the practicing physicians who staff those colleges to accept that the supply restriction protecting their wages is also the supply restriction killing patients. The 1991 memo is 35 years old. The lockout is still in force. The Uber driver in North Toronto with 12 years of medical training will probably never treat a Canadian patient. That